Hello, everyone, and welcome to the Medical Fitness Podcast. I'm Jeff Young, and in this episode, I'll be speaking with my co host, Dr. Thomas Hammett. Our podcast is brought to you by the Medicine, Rehab, and Fitness Institute and JY Kinesiology LLC, both of which are dedicated to medical fitness education and building the bridge between medicine, rehab, and fitness. You can learn more at mrfinstitute.org. The purpose of our podcast is to provide you with principle and evidence based content on all things related to exercise science, strength and conditioning, medical fitness, and building the bridge between medicine, rehab, and fitness. In this episode, Thomas and I begin discussing what I like to call the six components needed to create a healthy musculoskeletal system, a topic I cover in most of my presentations, including a recent presentation for the National Strength and Conditioning Association's Personal Trainers National Conference. But our talk ended up evolving into an even better discussion on how this concept is actually a small part of the bigger picture on why we need to merge the PT and fitness fields together. So, if having a better understanding of the medicine to rehab to fitness pathway is important to you, this podcast is worth your while. Let's get started, and I hope you enjoy the conversation. Okay, here we go again, everyone. Welcome to the Medical Fitness Podcast, our next episode, where it is just myself and my co-host and colleague, Dr. Thomas Hammett. Before I get into what we're going to be talking about today, let me just say, what's going on, Thomas? How are you doing today?
Hey, what's up, man? Good. We're both. You were just reminiscing on your lack of sleep lately. I'm dealing with the same thing. We've got a sleep regression at home with the baby, so
Yeah.
that's how I'm doing. If I look tired, it's because I am. But I'm excited to be here, man. Life's good, and it's a great day to talk about what we're going to talk about.
Absolutely. So, yes, so to the listeners, please bear with us because we're both a little tired, but we have a good topic today. And the topic is a concept that I think that I uh, kind of originated, but you all can be the judge. But I call it the components to creating a healthy musculoskeletal system. And so what I'm going to do is I'm going to start with a backstory and to give this a little bit of clarity. And then for those of you who are listening via audio, please just understand that we're also on YouTube. In the show notes, I'll make sure that I put the address to our YouTube link and podcast because I am going to be doing a share screen with a handful of slides to kind of guide the content. So you can head over there if that's something that interests you. But in any case, I'm going to start with a backstory to give some clarity, bring up the slide deck, and then Thomas is going this is going to be interesting for me because what you're all getting ready to hear is something that I've presented on many times at conferences, colleges, and universities as a guest speaker. And I also am an adjunct instructor at a local college here in New York City, where I teach a sports medicine and rehab course for undergraduate movement science students. And I actually, a lot of that course revolves around what this podcast is about. But I've never really asked Thomas about this or actually just sat down with a physical therapist and asked them what do you think about what I'm teaching and what I'm saying. So that's part of the reason why I'm excited about this. So with that said, here's the backstory. In 2006, when I was about 10 years in my career, I was in a right place, right time situation and was brought on to create and manage the fitness component in a Mount Sinai, Beth Israel facility here in New York City called the Center for Health and Healing. And I worked directly alongside our sports medicine and rehabilitation team. To give a little quick insight to that, our medical director was a physiatrist, and he was the director of sport and orthopedic rehabilitation for all of Beth Israel. He was on the New York Knicks medical team for 14 years. He was a consultant to the Yankees and Nets. We had another physiatrist who very much a part of this team, who was the head team physician and medical director for USA Women's Rugby for 12 years. Our head physical therapist spent more than a decade through Beth Israel as a primary physical therapist for the Knicks, Yankees, Nets, Liberty, and the men's and women's the New York members of the men's and women USA rugby team. So the point is that this was a pretty high level team, and when I was first brought on there, I didn't speak this language at all. Like I knew nothing about the language of sports medicine, rehabilitation, therapeutic exercise, pain management, and all the things they're associated. So this was new. It was a lot of anxiety that went along with it. It was a very small space at first, and so we were kind of like crawling all over each other. And I felt like, and this was my own perception, and I may be wrong, but I just felt like they were kind of looking at what I'm doing, like a vulture. And so in any case, there was a lot of correction going on. I was being uh, corrected on what seemed like a weekly basis on you need to do more cueing, you need to do more tactile cues where you're touching people appropriately. You need to include a lot more therapeutic exercises, and we don't like the heavier loads that you're having your patients lift and things like that. So in hindsight, I can clearly see that for the first 6 years or so, right around that amount of time, um, that I was there, I was kind of turned into, and Thomas and I have talked about this many times because it's fairly common occurrence in this type of atmosphere or just in the fitness field in general. I was turned into what I like to call a mini physical therapist. Thomas likes to use that phrase too, or corrective exercise specialist. So I've kind of been on that side of the fence. I know what it's like. It was a 6 year period on that side of the fence. And to give a little bit more clarity, what I mean by that was that through gushing, just working alongside rehab practitioners every day, these physiatrists and physical therapists, and all the discussions that went along with working and collaborating on a daily basis. Um, like obvious looks of apprehension from the physical therapist that they'd look and see what I'm doing with my clients and kind of cringe at times, and and kind of making it obvious that there were things that I was doing that they weren't real happy about. Being in that training environment and uh, yeah, maybe this doesn't happen with everybody, but what happened with me is being in that environment, I was kind of influenced over time to start training with lighter loads, more conservative exercises, placing a lot more emphasis on therapeutic exercises like strengthening the serratus anterior or focusing on a lot more on the core strengthening and multifidi and the transverse abdominis and Pilates mat exercises and kind of moving away from, not completely, but moving away from and placing less emphasis on more traditional exercises that I was used to because I was 10 years in my career at this point, and moving away from things like barbell exercises, barbell squats, deadlifts, overhead presses, freestanding barbell rows, and stuff like that. So I was really that's what I mean by that I was turned into a mini physical therapist or corrective exercise specialist. It was moving away from more traditional strength and conditioning approach and more towards a conservative therapeutic exercise approach. But the truth is it's a means to an end. And so I didn't think there was anything wrong with it. I actually started to I agreed with it. And because my clients were feeling better uh it was absolutely a means to an end. Here's where I'm going to very quickly bring up my slide deck and continue the story by saying that and I got to figure out how to merge these together and which to tell first. I think I'm going to tell the Dr. Smith story first. So basically, at about the 6 year mark, I met a physiatrist. I'm going to call him Dr. Smith. It's not really his real name, but I don't want to use his name without his permission. So I met Dr. Smith, and on the first day of his year-long fellowship, we had a PM&R fellowship program. It was a nationally recognized program. PM&R stands for Physical Medicine and Rehabilitation, which is informally known as physiatry. And he was starting his year-long fellowship. I met him on day one. We hit it off like brothers from day one. And Dr. Smith was an All-American offensive lineman in undergrad, so he was a high level athlete. He was a strength athlete. He competed nationally in Olympic lifting for more than a decade. He just missed making the 2004 Olympic team. But he was also incredibly smart, an MD, physiatrist. So the reason why I bring this up is because he really understood the big picture at a different level than most people that I've worked with. And it's because of his background in sports that have high levels of injury or high incidence of injury. So he knew what it was like to get injured, go through the rehab process to recondition himself back to an elite level. So he really just understood that big picture from not only an athlete standpoint and moving through that pathway standpoint, but also from an MD and physiatrist standpoint. And so to be able to pick his brain for a full year was invaluable. And he really brought me back into being a strength and conditioning coach. At the end of his year-long fellowship, he had to do or he had to give a presentation, which he ended up giving to about 25 physical therapists. He used me as a sounding board as he was creating this presentation. With that said, he also was using me as a sounding board for the whole, and we were using each other as a sounding board for that whole year. It just so happened that it culminated in this presentation where the gist, and I'm totally paraphrasing here, but the gist of his presentation was you physical therapists can do all the massage and joint mobilizations and gait reeducation and TheraBand exercises and balance exercises, etc., that you want. But if you don't get your patients strong, they're going to be right back seeing you again. The timing of this was perfect because now I was 6 years into it. So I now was really starting to understand the language of sports medicine, rehab, therapeutic exercise, pain management, things like that. So my confidence was way up. And another reason why it was great from a timing standpoint is because what he said was what I was seeing. I was seeing a lot of the patients coming back, just kind of being regurgitated through the system, either with the same injury or similar injury. So I really needed to hear it. And it turned me back very quickly into a strength and conditioning coach. But the good thing was that now I understood this language. And so I didn't just ditch the therapeutic exercises. Rather, I understood how to merge them and merge rehab and strength and conditioning concepts together. And so that now leads into the meat of today's podcast, which is, and the other part of the story on this slide deck. When I first started there, I was introduced to journal clubs. And I was 10 years in my career and I had never heard of journal clubs. Journal clubs are very common in the medical world and the rehab world, very uncommon in the fitness world, which is unfortunate because they should be a common part of the fitness world as well. The way we set up journal clubs were they were a monthly informal discussion on a hot topic. We called it a journal clubs because we would take an article out of a journal, and the journal was typically like a rehab journal, like the uh, physical therapy or athletic training journal or something like that. So it was hot topic of the month. And the good thing about it was it gave me the opportunity to listen to practitioners discuss this stuff with each other. I typically was like the one who sat in the back of the classroom hoping that nobody would call on me and didn't want to say and was nervous and didn't want to say anything. But it was a great atmosphere to be in. But it was overwhelming at first because I didn't understand the language. So it's this new language, and no one is explaining it to me in like a logical way. And instead, it's like one month we're talking about something going on with the foot ankle complex and how we should rehab that. And the next month it's the shoulder and maybe a rotator cuff tear. And the next month it's a knee ACL rehab, and the next is something with the low back, like a herniated disc or spinal stenosis or something like that. So it was pieces of the puzzle, but it wasn't a great way to put that puzzle together. So early on, it confused me. I was overwhelmed. I thought to myself, I'm never going to learn this. And then finally, and it probably honestly took about 2 years for it to kick in with me before the light bulb started going off in my head. But I started realizing that wait a second, it doesn't matter where the injury is located or what the injury is, we're always talking about the same things over and over. And so I kind of use that to develop this concept that I call, um, first of all, they were I just kind of assumed that we were talking about the components of creating a healthy musculoskeletal system. And so I developed this concept that I call the six components to creating a healthy musculoskeletal system. And they're really common sense. Which again, like in hindsight, it was a little bit frustrating now to me that I wish I would have had someone explain it to me in this way because it would have made my life professionally a lot easier. But here are the six components to, or what I call the six components to creating a healthy musculoskeletal system. And these are again, the six things that we were always talking about in journal clubs as it related to rehab, but also as it related to prehabilitation and to post-rehabilitation. So it's a much broader picture than just rehab. So here's the six components. We were always talking about the need for proper form, or in physical therapy, the terminology is commonly motor control, motor learning, neuromuscular control. But ultimately, that really, to me, just means we need to establish and proper form, teach proper form. That's where the cueing comes in. Have them practice proper form so it's ingrained in their daily life and with doing exercises. So, and obviously, improper form increases the risk of injury, which is a reason why it's a component of a healthy musculoskeletal system. We also were always talking about weakness being a problem, and also imbalances in strength being a problem, and the need to develop strength in the areas, in the case of rehab, the areas that they were rehabbing, whether it's shoulder or low back, hip, whatever the case may be. But I was thinking about it from a strength and conditioning coach and a fitness perspective, and thinking, well, yeah, that applies to that area that you're rehabbing, but this also applies to like the whole body, doesn't it? So anyways, the point being that obviously weakness and or imbalances in strength increase the risk for injury. So this is another reason why this is a component to a healthy musculoskeletal system, or creating one, and something that we need to address with programming. We were talking about a lot of injuries occur under conditions of fatigue, and therefore we need to improve the person's conditioning. And then I'll go through these very quickly, but we were talking about joint stability and the need to address that, if there is a lack, to assess it, to address it if there's a lack of, the need for posture and alignment, which is kind of common sense and obvious. And then lastly, the need for mobility and flexibility. So I have another slide. The next slide is related to what this means from a programming standpoint. But since I've been hogging up all the time here, I'm going to stop and I'm going to ask Thomas, what do you think? So what goes through your mind when you hear my stories, the evolution, what happened to me, as far as like turning in this mini physical therapist, and also journal clubs and talking about these things on a regular basis, and anything else that comes to your mind?
So, Jeff, I mean, the first thing that I'll tell you is that and I think you may like a little bit view your history of working at that Mount Sinai Beth Israel clinic as a circumstance of being surrounded by these people that were excellent, right? And and I think this happens to anyone that starts working in a medical clinic from the fitness world, because it's intimidating. Medicine it's almost from the outside, it feels like a cult, right? On the inside. So, regardless of whether your PTs and physicians have worked for the Knicks and USA Rugby, or if they're just really smart physicians that speak a different language than you, it's intimidating to get put in that clinical situation and feel like you know what you're doing, right? Our PTs and fitness professionals deal with the exact same thing that you were talking about, in terms of the fitness professionals, almost regardless of what we do from a training perspective, starting to go the direction of becoming mini physical therapists. And it's because they look around in the medical setting and they see what's happening and they're like, oh, okay, well, this must be some version of what I need to do. They're smart people. They get a lot of education. I'm going to follow a little bit of their lead. And unfortunately, what the medical system needs is not a post PT discharge mini physical therapist. I think PT has a distinct role in medicine that is different than what a fitness provider can offer, right? So what I think the first thing that I want to respond to is that what your experience is totally normal. In fact, it's more abnormal for that to not happen at first, right? And I've seen fitness professionals get totally twisted up and confused because they can't pull themselves back from the lens of, I'm in a medical setting, so I have to treat an impairment, right? And just because that's what, insurance-based medical care is: identify impairment, identify intervention, and fix impairment, right? Or address impairment. And in in putting fitness professionals in that setting, it's almost like they feel like they need to accomplish that same goal. And the fact of the matter is just not quite that true, right? Or it's true, but it's different because maybe I'll take a step back on that. It's true, but it's different. When someone presents to physical therapy, like any of my patients, they're going to present with a specific impairment in a specific body region, right? Shoulder pain or a hip pain or low back pain or knee pain. And my job as a PT is to assess and identify, to my best understanding what's going on and in terms of the development of that, and then what we can do to address their condition. And what insurance pays me to do is to identify, address, and coach people to a certain point, right? Like I get them to a lot of the time it's like 70 to 80% of their previous function related to that impairment. So related to their shoulder pain or their knee pain. So if they were able to reach overhead before, I get to get them to reach overhead, but maybe it's weaker, it gets tired early, or they can't lift as much overhead as they used to, right? And once people get to that point, we need the point of having a fitness professional embedded within a medical context is, yeah, pick up where I left off, but we don't just strengthen shoulders in the real world, right? Like we don't just strengthen knees in an isolated way or lower extremities, right? Like a right lower extremity is not the only thing that you need to focus on to address the bigger picture of your health. And when I'm getting people to work with a fitness professional after rehab, a lot of the lens is, yeah, man, I don't want you to come back here. So you need to get that joint and the muscles surrounding the joint stronger. You need to get the supporting musculature stronger. But also, there's some other health related things that may be contributing to this. And being regular with an exercise program is one of the best ways that you can prevent that from a heart health standpoint, a metabolic standpoint, just generally, right? So the purpose for me to refer someone to a fitness professional is it's not to be like, I don't want the mini PT thing. I want let's look at the big picture of this person's health. Let's look at what's best for them from a general exercise prescription to build strength in their entire body and not just a broken body part kind of thing, right? So what I say is it's normal. And I think hopefully PTs across the United States, I would say that what you experienced, Jeff, is really normal, but hopefully we're starting to understand that our limitations are pretty significant in PT, that we don't get enough time to do a lot of the stuff that's on this list. And it's even kind of hard for me to respond to the proper form, the strength development, the increased tolerance to fatigue and joint stability and posture and alignment and balance and mobility, because we get to work with people to a point, right, of doing this stuff. Like the strength development one in particular, because I think PTs would say, yeah, it's our job to help improve people's strength. But we know that it takes a long time to improve strength, right? To increase strength. You don't just increase strength after 6 weeks to 2 sets of 10, right? Like you really need to work at that for a consistent period of time to get beyond that beginner's range. So there's a lot that I have to say in terms of your 6 components. I think maybe I'll let you respond to what I've said first and see if you have thoughts or you want to dive into any of these specifically. But I think that's just my initial thoughts on your story and really how, I don't know, how this kind of stuff ends up shaping up.
By the way, most people looking for the services of a fitness professional are really just looking for information on how to get started on the right path, not to pay for training sessions every week for months or years on end. For the 60 to 70% of people with chronic disease and or joint pain, they're also looking for someone who can help them develop a clinically safe, individualized exercise program that takes their conditions into consideration. If you're interested in getting yourself, or for clinicians, your patients, started on a safe, cost-friendly medical fitness program, you can find more information about the virtual services we offer at mrfinstitute.org/services. We staff only degreed kinesiologists and exercise physiologists and will work with your healthcare providers in the design of your exercise program. For the clinicians listening in, you can add this virtual service as a reduced cost option for your patients. check out our website and send us an email, and we'll give you the details about this unique and much needed service. Well, here we are, 3,000 miles apart, and you absolutely nailed it. I mean, as though we were working alongside each other that whole time, because that is exactly what happened. I was so intimidated, um, and just felt like, man, there's this language out there that I'm never, like alluded to earlier, that I'm never going to learn. And it was this evolution that you really just described perfectly. I started to realize, and uh, piggybacking off of some of the things that you just said, that the benefit that I had was that I was treating the whole body, because now they're being referred to me, and I was seeing it from a different perspective. And again, it took years for me for the light bulbs to go off in my head, but I started to realize that, yeah, I am treating the whole body here. And part of our initial consultation was to talk about not just their musculoskeletal conditions. We were talking about their hypertension or their diabetes or other medical conditions, and so I had to take that into consideration as well. And so part of the reason why you and I get along so well and collaborate is because what is your passion also became my passion, because I started to see that, wait, there's a bigger picture here, and the bigger picture isn't just their joint pain. It is their overall health, and they're coming to me for the bigger picture now. It started with the smaller picture and the pain or whatever, but now it's a bigger picture, not only from a their own health and well-being standpoint, but also now they're going to likely be with me for longer than they were in physical therapy. It is a total body approach now. I am going to have much more time to strengthen them, to get them more conditioned, etc. And part of the reason why I bring that up is because another turning point for me in my career, a little bit of a turning point, was the Mount Sinai system then shut down for reasons that I won't bore anyone with. But then I ended up moving my practice over to a private practice facility, and private practice physical therapy facility that also included the physiatrist that I worked with, because they moved over there too. It had We had a chiropractor and occupational therapy, etc. And they didn't have journal clubs. So I asked the owner of this facility if he'd be interested in, and I would take the lead in starting up journal clubs. So we did. And since I was now the one moderating it, I formed or presented the first journal club. And my topic, the gist of my topic was, and I'll be interested in what you have to say about this, Thomas. Hopefully, we're going to agree. Um, that when you're discharged from physical therapy, generally speaking, the mindset needs to switch too. It just needs to switch. As a matter of fact, I know you're going to agree, because we've talked about this before, and you call it passing the baton, and that's exactly what it is. So the mindset needs to switch. It needs to switch from a more therapeutic, this is what you were doing in an acute setting. We were doing this with this part of your body, these joints, or whatever the case may be, and now we're going to switch. Um, Not in the sense that we're going to disregard that stuff. We're still going to include those things, but there's a way that we can include and merge those things within the scope of a total body, um, ACSM and NSCA guided uh, program. So I just feel like that's something that's just not happening for the most part. That switch in mindset, and part of the problem is the fitness world. As a matter of fact, it's a huge part of the problem is the fitness world, because there's so much of the fitness world that doesn't know ACSM and NSCA guidelines. They don't know how to put someone on a progressive periodized program and insert the therapeutic part into it as well. So yes, we could sit here and talk about the six components to creating a healthy musculoskeletal system, but I'm glad that our conversation has got a little bit broader than that, because that's what really matters. All this is just kind of an entryway into, okay, so what does that mean? Which I'll get into in the next slide or two, but I'm going to stop here and ask you what your thoughts are on what I just said.
Yeah, for sure. Uh, so the passing the baton idea, and I don't want to take the time to gripe a ton about like the physical therapy practice, right? But I think we're in a really good phase of change in PT. There's a lot of things that are forcing us to change right now, and if I was to reflect on the status quo of what you get on the first or second visit in PT when you're, getting informed about what therapy is going to look like, most of the time the patient walks out and thinks PT is going to look like some version of what I got in the first two visits, because really it's not super well explained a lot of the time. Some combination of therapeutic exercise and manual therapy and some neuromuscular reeducation, that proper form, motor control, and motor learning you have on the screen. But a lot of the time, patients don't really know what that means, right? And I think some of our downfall in PT is educating people on the phases of rehab itself, right? So a lot of people go into therapy blind about what the therapy experience is going to be outside of the interventions that they might receive. And even then, a lot of the time, they don't understand what those things are going to do, other than, wow, this manual therapy feels really good, and wow, this exercise is kind of hard. That's most of the experience. Hopefully I really like my therapist, right? But to be really good at making that handoff, Jeff, there's something that you and I had talked about, I think you'll get into later, is the idea of, okay, so people come in with an acute impairment and they're in this inflammatory stage, but that doesn't last forever, right? In fact, it's got a pretty predictable endpoint depending on what you're going through, whether it's an acute injury or post-op. And there are people that don't even present with an acute injury, right? That are just dealing with a chronic condition. And that's a whole different thing. But once we deal with that inflammatory stage, there's a pretty predictable time frame where my focus is going to be a lot less helping reduce pain and improve basic mobility, and more, let's look globally at what we can do to improve all the components that you have on the screen, and doing it in a systematic way. First we'd focus on motion and in that specific joint and strengthening the muscles around it. And then really focusing on strengthening major movements at that joint too, right? So anyways, I think it is very dependent on the phases being presented, where we get to be really effective at handing off to a fitness professional. And if we can explain to them, part of the big picture is that, at the end of this thing, there's this both continuing rehab and prevention that looks like ongoing exercise, not just for your shoulder or for your knee, but for your entire body. When people understand that, it makes the handoff a lot easier. Yeah, I think that's most of what I would have to say to your points, Jeff.
I'm so glad that you said what you said. I think let me go to the next slide. Yeah, I'm actually going to bypass this slide for a second. We might come back to it time permitting, because I know we're kind of winding things down here. But yeah, I knew I had the slide on what you just talked about, and I'm so glad that you did from your perspective, because it's going to make it easier for me to explain that yes, there are stages of rehabilitation, and as Thomas just said, the first stage, this is outside the scope of fitness professionals. This is where PTs are going to be doing their joint mobilizations and massage and whatever tools and modalities they have to try to help facilitate the healing process, which, like Thomas said, has a pretty predictable endpoint, and it corresponds with the inflammatory stage, which is the reason why, another major reason why it's outside of our scope. And then, as he also said, then stage two is which corresponds with the repair stage of healing, which is, again, it's outside of our the fitness professional scope if the injury is in that repair stage. But once the injury is healed, then we can do these things. We don't have the exact same skill set or tools that a physical therapist has. We can't do the massage and joint mobilization, stuff like that, but we can place somebody on a flexibility program to help improve their range of motion. And then stage three, which is typically, again, it's not physical therapist's fault, it's more insurance's fault, dictating these short um, uh, number of visits, small number of visits to physical therapy. But this is typically where physical therapy ends, where, again, as Thomas talked about, it's things like the movement, restoring the proper movement, starting to begin the strengthening process, whether it's isometric or light loads, gait and balance training, if that's applicable, things like that. But this is now what I'm getting ready to bring up on the slide deck. This is where the baton then needs to be passed. And again, I spent a lot of time in the sports medicine and rehab undergraduate course that I teach for a movement science program talking about this stuff and the need to pass this baton so that the so it's not just in sports physical therapy with athletes where this happens, but it's with everybody. And so, yes, it would be extremely helpful if we could merge our worlds, crash our worlds together in a very positive way so that physical therapists were explaining. I'm just a huge believer in creating an informed consumer, and there's no reason why the consumer can't know these things, at least in a general, layperson's way. So explain that, hey, this is what we're going to be doing with you, but there is a fourth stage, and we might have time to start that fourth stage in physical therapy, maybe not. But whether we do or not, we need to create a more long-term plan of care, and this is why we need to merge our worlds together. So, yes, couldn't agree more. And let me just backtrack real quick to this slide and just say that those six components of a healthy musculoskeletal system, over the course of time, I started thinking, well, then how am I going to implement these things in the design of a program? And again, this is something I present on all the time. It is so common sense. It's so easy. And not only should I think everybody should know this. Physical therapists should be aware of this, what I'm getting ready to say in this slide, because it's a way to pass that baton. Fitness professionals should know this because it's a best practice approach. And I educate my clients on this because I think it creates an informed consumer. So in any case, how do we take those six components and merge them into programming? It's literally as simple as we want to balance their flexibility around joints. So the way I say it is where they're tight, get them mobile. Or that's just another way of saying that we want to balance um, mobility and flexibility around joints. And that's nothing. There's no magic to it. All that means is we need to start with a joint range of motion assessment, which is outside the scope of today's podcast to talk about in any detail, but it's a missing link in fitness. Fitness professionals don't know their joint ranges of motion for the most part. They're not assessing them, and if you don't assess them, then you're going into this guessing. But if you do assess them, then it makes it a lot easier to place the person on a proper flexibility training program because you know where they're tight. So in any case, we want to balance their flexibility. We want to balance their strength. There is no magic to this. It's literally just a product of strengthening every major muscle group in the body, which follows ACSM and SCA, or in other words, the governing body guidelines. The way I phrase that is where they're weak or hypermobile, get them strong. We want to make sure we do that with proper form. We want to develop their strength outside of the beginner domains. In other words, we don't want people to remain weak. And there's no magic to this. It's just a product of placing them on a progressive, what's called a periodized program, which we alluded to in an earlier podcast, and we'll talk about more in a future podcast in more detail about what that means. But the point is, we want to progress their strength across a spectrum of repetition ranges. It's no longer the 2 or 3 sets of 10. Now we want to spend some time in higher repetition ranges like 12 or 15, and sometime in lower repetitions like 8 reps per set, 6 reps per set with increasingly heavier loads and 4 reps per set. And then lastly, and we just not going to have time to talk about this today. This will have to be a future podcast as well. But we want to determine their safe initial loads, which are typically warm up intensity loads, progress at safe rates, which basically just means um, progress in small tolerable increments, and insert what I like to call joint friendly exercises, which again, we won't have time to talk about today, but just know that what I mean by that is that there are exercises which tend to be safe for the knee, for the hip, for the low back, for the shoulder, for the neck, that are commonly used in physical therapy, and fitness professionals should know what they are, and then at least understand the general concepts so they can then merge that into the overall programming. So this will be the last slide. I'm actually going to do a stop share now, and as we wrap this up, um, I just want to say that I'm glad. I definitely want your final thoughts, but I'm glad that we had this again, kind of a 30,000 foot bird's eye view discussion because it's important. These are important concepts for everyone to hear about, whether it's physicians who are referring off to fitness professionals and physical therapists, or PTs or fitness professionals, because we need to crash and merge our worlds together in a positive way. And if we all just understood these basic concepts and how they do merge together, it's just going to make a better situation for everybody. So, what are your final thoughts on this whole topic and anything that was said?
My final thoughts, I a lot of the stuff that you shared, Jeff, what's tough about talking about this stuff is that there's a pretty significant overlap, right? Like
Absolutely.
a lot of the stuff that you showed is in my domain, it's in your domain. It's not even worth
Yes.
it to split hairs on who does what.
Yes.
There may not even be a specific natural handoff point, though I would argue we should try to make one, right? We should try to be
Yes.
good at identifying when that handoff point is, and when when my expertise has done what it needs to do, right? And it's time to move on. I think a lot of the time what's tough about this stuff is that there's so many overlapping providers within the medical context that do things that look similar, that I think from a consumer standpoint for patients, it gets confusing. And one of the things that I hate to hear the most in our clinics is why would I go work with a fitness professional when I can do PT and it's covered by insurance? And it feels like we're doing the same thing. And if we ever get that, it's clear that we haven't communicated our unique value, right? What your value is compared to my value, why we do certain things and the phases that we do them. And it's a complicated world. I don't expect patients to understand it all the time, but we can be simple about it, right? So I'm a physical therapist. My value to the system is to reduce physical barriers to people's movement, to people's happiness, right? If we overcomplicate it with this movement system expert baloney, and to be honest with you, it's just my job is to reduce people's physical barriers to movement. Sometimes that means the acute stuff where we're doing if we use our RICE acronyms, right? It's the RICE of active rest, R being rest, ICE, which has some conflicting evidence and people don't like so much anymore, but we don't need to get into that. Compression and elevation, and that's the acute phase of therapy. A lot of the time, we do movement that is really the active stuff that doesn't hurt the joint or hurt the impaired tissue. And once we get out of that phase, there's a different RICE that I like to use, which is reduce inflammatory choices and exercise daily, which is RICE. It's RICE instead of RICE, right? But for most people that come into PT these days, it's not always the inflammatory stuff that we're dealing with. It's more of the let's reduce your inflammatory choices and exercise every day. And my job as a PT is to get people to the point where their impairment isn't stopping them from doing the things that they care about doing a ton. But then my job is also to help people know how to not have that happen to them again, right? Or to reduce the likelihood of that happening at whatever cost I can. And most of the time, the best things that I have to make that happen are a referral to a fitness professional or some kind of ongoing exercise program. And too often we give these paper handouts to people and say, do this forever. And it's not good enough because there's no progression and there's no plan, and it requires people to figure it out on their own. And you get bored of doing pieces of paper for any extended period of time. I did PT when I was younger. I know that I stopped doing my exercises after 2 or 3 weeks after PT was done. It's just the way it is. It's not a good resource. We have to give people a resource that's exercise beyond the PT plan of care, and that is addressing those other inflammatory choices, and that may be all kinds of different providers. And once I address that stuff, that's the end of my scope. And I need to be willing to hand off to these other people who are the experts at addressing those other components. And, again, getting into the specific factors that you presented, Jeff, they're all important, right? Like I need to know how to strengthen and provide cues on proper form. And I may give different cues on proper form than you do, but it's more the line that I draw on, okay, I've addressed the stuff that I need to address, and it's time for this person to move on. And helping people, and it's really so much of the time are they in a place where they can somewhat independently care for themselves? And if so, at least have an independent plan that extends beyond me, right? That they don't have to utilize medicine as much as they were when they were seeing me and seeing their doctor and seeing a surgeon. When that's done, it's done, and they get to move on. And a lot of the time we say prior level of function, go back to doing whatever it was you were doing before. And I would just state that that's just not good enough for most people. That to go back to doing what you were doing before just isn't good enough. And that's where the fitness professional comes in. It's where the nutrition professional comes in. It's where thinking about smoking cessation and all that other stuff comes in too. But of course, all the stuff, all of the overlap content that you presented is important. I think we probably need to have more conversation around the roles that we play and just how we make that handoff too, which you and I talk about all the time. But anyways,
Yeah.
that's my rant. That's my soapbox for today.
No, I absolutely love it, man. I could listen to it all day, and I'm just so glad that we have this platform as an opportunity to talk about this stuff and our alternative views, and and get them out to people who are interested in listening to it. And it's kind of interesting because now we're wrapping this up, and going into this, I thought it was going to be about these components to a healthy musculoskeletal system, and we ended up talking about that a little bit, but a bigger picture that I'm glad that we talked about because it needs to be heard, and our alternative view needs to be heard. So, Thomas, thanks so much for all your insight and your input, and we will continue this and also with our future guests on the podcast. So, thanks again, and we'll talk soon.
Good stuff. Thanks, Jeff.
Do you need assistance in connecting with a fitness professional in your local area or virtually to add this connection to your patient services? If so, please email mrfinstitute.org@gmail.com. Please also remember to check out mrfinstitute.org for information on how to learn more about the education we offer and to stay current with our podcast series. Thanks for tuning in, and we'll see you in the next episode.